it is so encouraging to see all our seniors, and they are early morning. They get up at 6:30, and they are before 6:30 they join. So we will start with the new something new. We have learned introduction, pain management, and then communication thoroughly. Now it's the time to discuss something else beyond cancer, because most of the time we discuss with cancer, palliative medicine with cancer, but it is not only cancer. So now we this month we will go beyond cancer, and we are very fortunate that our students, I think, till now teachers were speaking. Now the turn of our students have come. The students who have passed from Tata Memorial Hospital. So whole month the turn is of all the students. Although they are not students now, they have become faculty in various places, various institutes of excellence. They have become in various places. So Pankaj is going to speak about how to handle a patient who is suffering with chronic kidney disease. Pankaj, we know everyone know Pankaj. I think initial 3-4 batches, Tata Memorial Hospital ke everyone knows them very well. So when I went to Manipal Hospital, first time I face to face I interacted with Pankaj, and I realized that he's quite boy, but and he is always smiling. But when I saw his papers, I think he is writing very good research paper, and again he is a very good, he is a brilliant star of an excellent team of Naveen Salins at KMC Manipal. Besides the Tata Memorial student, I think the Bruce Davis Gold Medal, which everyone dreamed to dream that everyone's dream of palliative medicine student, that I should get this Bruce Davis Gold Medal, which every year IAPC is giving to the brilliant boy, and he is the Bruce Davis Gold Medal in 2015. Besides this, he has also received. I think he has. There is no. I think there is no mention, but I remember that he has received a good grant from IAHPC, and then from I think Supportive Care Conference, and then he received those grants, and he attended those conferences. Travel grant he received, and I think all getting in this age, all these grants, I think it's a big thing. So Pankaj, over to you, and we are very happy today that our students are starting now. Students created by Dr. Mariam and her team. I think they will do the hangama a whole month, that how to handle a patient who is suffering beyond cancer. Thank you very much, Pankaj.
Thank you so much, ma'am. It's my pleasure to be here, and also today I'm a bit nervous speaking in front of my teachers. So again, thank you for giving us opportunity for this, and I hope we will do the justice to the topic, and will cover all the things required for students as well as other palliative care physicians. I will share my screen from here. Yeah. So today I will talk about palliative care in chronic kidney diseases. Before I start, I would also like to thank people. One, Dr. Naveen Salins sir, who gave me opportunity to work in this kidney disease independently and completely to take charge of CKD clinic here. Second, Dr. Nandini Valat ma'am, who gave this idea to start a master class in palliative care in end-stage renal disease, and we conducted a CME here. And last, Dr. Frank Baran, who gave a master class and who really taught us, and even after that he is continuously in the touch and sharing the resources with us. Okay, so chronic kidney diseases, It's one of the largest population we have in India because of the diabetes and hypertension. We have a lot many of cases. Few of them are diagnosed, and still a large number of patients are still not diagnosed, or they are in community and they are suffering with those ailments. And a very few number of patients are receiving dialysis. They go to hospitals, they get dialysis, and a lot many of them, almost more than 50%, they default from the dialysis. They either cannot afford dialysis, or for some reason, for some symptoms or some other reasons, they default from the dialysis. They do not complete. So it's a very important discipline where palliative care can be integrated, and our principle of palliative care can benefit the patients with chronic kidney diseases. So here I will be covering on a few topics like basic nephrology that we should know about CKD patients, what all are the suffering associated with CKD and how we can measure it. And in brief, I will talk about the symptom control, and also how we can identify those patients who may benefit from kidney supportive care, or those whom conservative management can be started, and they need not to be on dialysis, or in some patients if withdrawal from dialysis is required or withholding is required. I will not talk about the basic principle of palliative care here, because as a working in palliative care, we already know about those things. I will not talk much about the CKD, but basic things that is needed in our day-to-day practices. One thing that is how to calculate the creatinine clearance. So everyone, we get the result from the lab side. This is the serum creatinine, and we go to, if required, if it is like more than 1, we go to the Medcal and calculate the Cockcroft-Gault formula. As a resident, I will not recommend that because it's important to calculate by hand, and I think because we are not involved in mathematics anymore, so let's do some calculation. Beyond that, it is important because this formula shows that how create clearance is measured. So there are 3 factors or 4. One is age. Like we have, most of our patients are more than 60 years of age, and our create clearance decreases if patient's age is advanced. Second thing is lean body weight. That is the body weight of actual body weight of patient, that is like involving the muscles or fat. Third is the creatinine level. So if creatinine level increases, the create clearance may decrease. And fourth is gender of patient. So if a patient is a female, create clearance will be low. So if these are the factors, like patient has advanced age, if patient is cachectic, or is a female gender, then create clearance will be low. So even if it is same for 2 people, the create clearance may differ, and we have to be mindful of that. In some practice, like a few nephrologists says that this may not be the ideal formula, and in some cases we need to calculate create clearance based on other formulas or other lab investigations. But I think for most of our purpose, this CG formula works. The second thing is CKD classification. So based on the create clearance or glomerular filtration rate, it is divided into 5 broad categories. In our interest, that is this CKD classification is very important. So if I'm sorry if this is wrong, actually it should be at increased more than 90 and at kidney stage 1 if it is more than 60 to 90. Okay. Then stage 2 is 60 to 90. Stage 3 is 30 to 59. It is also classified into A and B based on 30 to 45 and 45 to 59. And based on this GFR, we use the drugs, most of our medications that depends on GFR. So it is very important to calculate the GFR and then use the drugs accordingly. Most of the patients who require kidney supportive care or kidney palliative care are those patients who are in end stage kidney disease, that is either stage 4 or stage 5, or those patients who are on dialysis or have some indication to start the dialysis. So there are many drugs that we use routinely and that can inversely affect the kidney functions. So most commonly that everyone knows, the NSAIDs that can affect kidneys. Some of antibiotics that we use like aminoglycosides can worsen RFTs, and we have to be mindful of that. Bisphosphonate like zoledronate, if not given with proper hydration or patient has AKI, may worsen the renal functions. A lot of chemotherapies, especially palliative chemotherapies, may cause worsening of RFT, and then we have to monitor more often if patient is on chemotherapy, and especially palliative patients in palliative care who are more sick and they are prone for having side effects of those palliative chemotherapy. Sometimes and that though it is controversial, like these ACE inhibitors and ARBs may worsen the GFR, but it is still used as a renoprotective because it inhibits the RAS mechanism and it protects the kidney. So usually it is used. Although when we start ACE inhibitors, or mindful that we know the recent create clearance. So many times people ask like how often we should repeat CKD. Is it on the every visit or monthly or this? So usually we say like if a patient is on any drug that can worsen his create clearance, then at least every 3 weeks we should monitor his create clearance. Otherwise, if there is any episode like any infection or a severe diarrhea, vomiting that can affect the patient's kidney functions, that time we should repeat the kidney function. So the common medications that are used like morphine, tramadol, tapentadol, they are excreted through kidney. Morphine, we reduce the dose if create clearance is less than 60, and we should not give it if it is less than 30. Same is for tramadol and tapentadol, although both the drugs are recommended in CKD, but the doses are quite less. And we know on the fentanyl and methadone, they can be given safely in patients with renal with the CKD, but still we have to be a bit cautious in patients, because sometimes there may be in the stories of the drug inside body, and the fentanyl especially, it is not hemodialysed, so especially in large dose, and that is started suddenly, that at that time it can cause toxicity. Some antibiotics like ciprofloxacin, levofloxacin depends on renal function. OHAs like glimepiride, and sitagliptins that are dependent on renal functions. Gabapentinoids also like it depends, but it is still safer to use in the reduced doses. Mirtazapine is recommended up to stage 4 of CKD, but beyond that we should be cautious. And also almost all medications we start with a lesser dose if we are not sure. So then comes the symptom management. So before I start what all are the symptoms, there are some research questionnaires or quality of life measures that is commonly used. So these are the list of quality of life questionnaires or symptom assessment questionnaires that has been used in the CKD patients, and some of them are modified for CKD patients. Most commonly that are used in kidney patients. So this was a question that was asked in one of the internal exam for MD students. What are the quality of life questionnaires that can be used in patients with CKD? Those are not on dialysis. So basically there are not much difference, but there are some quality of life scores that are used only in patients with dialysis. So these are all quality of life that has scoring system that has been used. Mostly KDQL, that is kidney disease QL version 1.3, it is most commonly used, and it's a brief version. EuroQL 5D5L, it's although non-disease specific, but it has been found to have it matches with other kidney disease specific QL scale, so it is also been used. IPOS, I think everyone knows, like it's a palliative care outcome scale, and it has been modified for renal patients, and I find it very simple, and it covers almost all subsets of quality of life measurements. So although it's not a quality of life tool, but still it can means we can have a broad idea of quality of life. ESAS is mainly for symptom assessment, and it is also been modified for the CKD patients. And this SF36, it's also very commonly used quality of life tool for kidney patient. So these are some of those tools. Okay. So this is one short study we did in our KMC, where we enrolled around 80 patients on 85 patients on CKD, and we found that these patients had a lot of symptom burden. Although these are not patients who are fitting for palliative care, we did it for all dialysis patients. And in that patients, almost half of them had some pain, and 20% of patients had moderate to severe unresolved pain, and they admitted that it was not taken care of. And if we see, and there is a lot of other symptoms that almost half of them have, like fatigue, lack of appetite, restless leg syndrome, poor mobility, sleep disturbances, pruritus, and breathing difficulty. Apart from the physical symptom burden, we find out that there is a lot of communication gap. They wanted to discuss with others, maybe family members or the nephrologist, but they didn't had enough information or communication with them. Although it's a private center, and most of the dialysis patients who are from the low income group, they used to go to a government center. But still, in those affording patients, almost 50%, like 47%, had some financial need, and that was not addressed. And very important thing that almost 80% of the patients, they felt like they are spending a lot of their time in the healthcare facility, either for the dialysis or the complications related to the CKD. So this was about our study, just for to know how much burden the CKD patient has. So I will go back to the renal functions here to understand the symptomatology in CKD patients. So kidney doesn't have only, like, it does not filter our blood and filter out the toxins, but it has a lot of a role in metabolism and like endocrine functions, or in blood, for erythropoiesis and all. So if our kidney is affected, it may lead to a different variety of symptoms here. So if we leave out the kidney that causes mainly the uremia or reduced urine output, CKD is always a progressive disease. Like if a patient is having CKD1, after some time, most of the patients will develop into the CKD 4, 5, and all. So it's a progressive disease, and like it's in the most of the patients, it's a slowly progressive disease, and so that's why they have a lot of side effect, the suffering for quite a long time. If we go from head to toe, the multiple complications, like these patients are prone for ischemic or hemorrhagic stroke, and that can be very severe. Here we had seen a lot of patients with a large thalamic bleed or a severe stroke, and that can very adversely affect their quality of life. Many patients on the dialysis, dialysis develops the symptoms of depression, and unfortunately a majority of them are not diagnosed, and they have not been referred to psychology or psychiatry for the assessment and treatment. Cachexia is very common, and on the other hand, if a patient is not on dialysis, they may develop facial edema. A lot of patients says that there is altered taste or anorexia in those patients. It is again multifactorial, maybe associated with a lot of reasons. A lot of patients develop nausea, vomiting, especially nausea. They have persistent urge to vomit, and they cannot vomit, and it's a very difficult symptoms for those patients. And when we talk about the CKD patients, it's for the years altogether. It's not like malignancies, when it can be for the shorter period of time when they are on chemotherapies. So this is very disturbing, having persistent nausea. Breathing difficulty, it can be because of various causes. Most commonly, it is because of pulmonary edema in patients with CKD5. If it is not adequate dialysis or they are developing water retention. But it can also be because of other causes like infection, myocarditis, heart failure, and all. Then these patients are very prone for recurrent sepsis. We had seen a lot of patients coming to ICU with severe sepsis, and it may be because of the dialysis or peritoneal dialysis that is causing, or itself because of low immunity. Especially in today's time, in COVID time, we are seeing a lot of patients developing COVID are going into severe sepsis, or they deteriorate very fast. The mortality in CKD patients are quite high than other patients. And they are prone for pancreatitis, and it can be recurrent fistula failure. There may be recurrent abdominal pain. There are the crisis time, like those patients who are diagnosed with dialysis, and before they are in the waiting for transplant, a lot of crisis comes and goes, and these need to be managed. During transplant, when they are on various therapies to decrease their immune response, or post-transplant also, like recurrent infections and all, can cause transplants crisis conditions. There are continuous financial crisis among the family members. These patients are prone for DVT, peripheral neuropathy, that is very severe and cause a lot of disturbing symptoms. They have a persistent itching, that is uremic pruritus, restless leg syndrome, peripheral vascular disease that also can cause the severe ulcerations, gangrene, and many a time these patients require amputations also because of these complications. But these are not the whole like a full list of symptoms that is caused by CKD. These are way beyond this list. So and these patients suffers, and there are a lot of suffering. In one of the study, it has been identified like these patients with CKD have the symptom burden as much as the advanced cancer patients. So we should actively look for symptoms in CKD patients also. So this is some of the list of abnormalities that are present in patients with CKD. Here, if you see I means these patients improves with dialysis, and D like adynamic bone disease or some of the neuropathies that can deteriorate on the dialysis, and P is like that persist even on the dialysis. So I will not go onto the list, but those in the red you can see that is actually can deteriorate on the dialysis also. So like amyloidosis, and their patients it may persist or deteriorate. Patients have muscle cramps, especially while they are on dialysis. They can complain of that. If a patient is on peritoneal dialysis, patients are more prone for peritonitis and all. Okay, so and like dialysis may have some complications also associated. A lot of patients complain of hypotension during the dialysis, and that is the reason like a lot of patients are not able to do dialysis completely or regularly because of persistent hypotension during the dialysis or after the dialysis. So when we come to symptoms, I will come now to individual symptoms. So first and foremost, like it's a very common symptom is pain. Most of us know about the management of pain. I will not go very deep in that, but a common cause that is there in CKD patients who are on dialysis or not. So it can be a majority of them have some musculoskeletal pain or neuropathic pain. So because these patients are more prone for osteoarthritis or osteoporosis or renal osteodystrophy, a lot of patients complain of the limb pain or back pain associated. And it is important to correct the calcium, vitamin D, and phosphorus level in those patients. Also, these patients may develop carpal tunnel syndrome and can cause severe pain at that time. Some pain related to the dialysis process. So as I said, that cramps may increase while the dialysis, or also they have the fistula, and that can be painful where they insert in the abdomen the peritoneal dialysis catheter. It can be painful, and sometimes it develops either fistula failure or a local infection, and that can increase the pain. A lot of patients have peripheral neuropathy, and that causes severe pain, and it is very common as we discussed. There is ischemic pain associated with peripheral vascular disease, and that cause pain. Many patients have angina pain, and other that may be related to like they have a mass polycystic kidney disease or malignancy associated, and that can be a cause of pain. So when we talk about the pain management, we see like it is very commonly undertreated and also underreported. The patient fears that if I tell that I have pain and doctor will prescribe a pain medication, it will further affect my kidney functions. So a lot of time it is underreported, and also it is undertreated also because many times physician is not sure about the pain management. And as we know, for kidney patients, everyone gives the underdoses, although if it is recommended or not, but they always will give underdose like ultra, set, semi, we always see in patients with CKDs. So it is undertreated. And there may be a lot of cause, as we discussed, and that can cause these pain. And as we discussed, that they will not admit or will seek relief from it because of the fear that they have. If we go by the general principle, so it applies for the CKD patients also, that we have to assess the pain and the cause of pain. And WHO letter is validated for CKD populations also, but we have certain drugs. So like for step 1, we should not use NSAIDs in most of the cases. Step 2, we should not use the codeine, that usually converted into morphine. And morphine, because its active metabolites are excreted through the kidney, we should not use. Adjuvant analgesics we can use with the caution that we will discuss. So NSAIDs I would like to discuss here before we start WHO later. That at all we should try to avoid NSAIDs as much as possible. But if we are not able to achieve a good symptom control on other medications, sometimes we had to use NSAIDs. So in that case, first assure that like there is no other thing that we can use that is in renal safe. Take a renal physician's advice and always discuss with patient why we are using and what potential harm it may have. Sometimes nephrologist says that there is like if in the patients who are anuric, like there is no other renal function left, the patient is not producing any urine, still we can use NSAIDs to control the pain. But as I said, that kidney is not only for producing urine, it may have some other functions left also, and it can still damage the kidney. So we have to be a bit mindful about that. Okay. So this is the step ladder that we use. So paracetamol is the drug in step 1 that we use for mild pain. We can use up to 4 grams per day safely. That's not a problem. So we can start with 1 gram and give up to 4 times a day. With that, the adjuvant analgesics. So adjuvant analgesics that we used usually for neuropathic pain may be antidepressants or anticonvulsants. Both TCAs and gabapentinoids can be used. Although the side effect of TCAs are more, and that anticholinergic side effects are more in patients with CKD. So usually we avoid or decrease the dose. Gabapentinoid, because it has some effects on other symptoms also, are preferred. So we prefer gabapentin. If it is less than 15, we start with alternate day of gabapentin 50 mg. And can give up to 100 mg alternate day. If a patient is on dialysis, so after every dialysis we give the gabapentin. Pregabalin can also be used in such cases in 25 mg. Other anticonvulsants like valproate, carbamazepine, phenytoin can be used for neuropathic pain. Second, for the step 2, we use the weak opioids. So recommended drug are tramadol and tapentadol. So it can be used if it is less than 15 or patient is on dialysis. We usually use 50 mg BD, like that maximum dose is 100 mg. If create clearance is 15 to 30, then we can use 100 up to 100 mg BD, and that is like 200 mg, and we can use if it is up to 30. Same is for tapentadol also. Usually the side effects are lesser in tapentadol, so we prefer starting with tapentadol rather than tramadol. And third step is for unrelieved moderate pain or severe pain. So in that case, opioids are the drug of choice. We in India we have only the fentanyl and methadone. So fentanyl it is available as transdermal patch, and we do not recommend it for acute or unrelieved pain. So we start with IV medications. IV fentanyl or subcutaneous fentanyl. Try to understand the dose that is required, and then go for same amount of same strength of fentanyl patch, because it will take around 6 to 10 hours to start working, and we don't know how much requirement we may have. Other very important drug is methadone, but it is a bit difficult to titrate, and we usually recommend if patient is not able to afford or cannot get the fentanyl patch, then methadone should be second line of drug. But it is renal safe, so it can also be used. So this was about the pain management in brief. Then other symptoms, other common symptoms are uremic pruritus. So uremic pruritus is very, very common, and the thing is, whenever we think about H, we think like it will be relieved by the antihistaminic. But in kidney patients, majority of it is not related to the histamine. 90% is not related to the histamine, and it may not benefit. The antihistaminics may not benefit here. So these are the management of uremic pruritus in the short. Like first, we look for the correctable cause, or what can predispose patient for the pruritus. So look if the patient is undergoing adequate dialysis, have parathormone level corrected, calcium, phosphorus is managed clearly. And look for other ADRs that can cause pruritus. Iron deficiency also can cause pruritus if the patient has some other allergy or dry skin, and that should be corrected. The non-pharmacological measures are like patient should have good hydration, should use good moisturizing creams, and patient should not use the hot water or hard soaps that can cause dryness of skin. Many times phototherapy is recommended if the patient is having severe pruritus, and sometimes there has been studies on acupressure and TENS in management of uremic pruritus. When we come to pharmacological management, the first line is to start with topical agents. So the moisturizing cream with menthol, it usually relieves to some extent. If it is not helping, then topical promethazine, and that can be mixed with some other like menthol, phenol, or camphor can be used. Sometimes the capsaicin patches or cream can be used, and gamma linoleic acid cream may be used topically. As I said, the gabapentin can be used for other purpose. So other indication is uremic pruritus. There has been evidence that gabapentin 50 mg can relieve the pruritus associated with it. And if gabapentin is not available, pregabalin in the dose of 25 mg after each dialysis can be used. Other drug that has evidence is sertraline. Sertraline 50 mg per day can be used if it is not relieved with the gabapentin or topical agents. Then comes the restless leg syndrome. So it is again a very common symptoms and a very disturbing symptom, because restless leg usually occur in night, and patient that causes lack of sleep, and so lack of sleep and can cause other symptoms like because they already have insomnia and pain, and restless leg syndrome can worsen those things. So iron, the cause, because it is, if we look for the mechanism, the iron is involved in that. So if there is iron deficiency anemia, treated with IV or oral iron. If there is hyperphosphatemia, that should be corrected. Look for any other drugs that can contribute to restless leg syndrome that are usually dopamine antagonists. So usually patients, if they are on metoprolol or other some of the antidepressants, those should be used. Non-pharmacological measures like they should not use alcohol or caffeine, especially in the night. Try to use some mental alert activities like solving puzzles, some board game, especially when they are on the dialysis they can use. Some of the exercise also like paddling can also be used in those times. Then for pharmacological management, again, the gabapentin can be used in the same dose like 50 mg HS or alternate day. Then there are some drug that is dopamine agonist like pramipexole and rotigotine or ropinirole. These drugs are also recommended. So in one of the study, it has been found that gabapentinoid are as effective as dopamine agonist, and one of other study has shown the benefit in gabapentin over pramipexole and the placebo. So these can be used. Third symptoms, very common symptoms as we discussed, was the nausea or vomiting. So again, we should try to correct every correctables. Use look for the drugs that can cause and the vomiting or nausea sensation. And also these patients are many a times these are bed bound and that they cannot move around. It may or the plexopathies can cause the delayed gastric emptying. And so look for other causes also. If like patient is having constipation or peripheral neuropathies that can cause nausea, vomiting. Non-pharmacological measures and that we generally use in palliative care like relaxation, MSA therapy, acupressure in some cases. Ginger has been found to relieve the nausea in some extent, and to avoid those spicy or greasy food that can aggravate the nausea should be avoided. Pharmacological management, usually we prefer metoclopramide if patient is not having restless leg syndrome. In some patients who are not constipated, we can use ondansetron also, but it should be avoided if patient is constipated. If it is predominantly nausea, then usually those drugs that are centrally works better. So like haloperidol or olanzapine can be used. If patient is not able to take orally, then IV or subcutaneous haloperidol can be used. Then the dyspnea, as we discussed, like these patients are very prone for breathing difficulty. The cause can be either it can be pulmonary edema, maybe anemia or infections, and sometimes also associated with the anxiety. So our general principle of non-pharmacological management of dyspnea works very well. Also here important is we can judiciously use furosemide or and also sometimes ultrafiltration can be considered even those patients who are in hospice or palliative care centers with discussion with the family, and if appropriate can be used for just for the management of dyspnea. Again, the opioids. So opioids, it has been there are studies for fentanyl either as a OTFCs or subcutaneous injections intranasally. It has been found to have to relieve the breakthrough episodes of dyspnea. Many studies also suggest that we can still use the small dose of morphine that for dyspnea, like 1 mg subcutaneous or 2.5 mg oral can be used. Then depression, as we discussed, that it is important symptoms and usually underdiagnosed. So usually we should look for it, and treatment is usually first line is sertraline or escitalopram. A patient is in not in CKD5, then mirtazapine can be used. So this was about the symptom burdens that we have usually. The next important part comes like how we will identify the kidney patients. I don't know how much I will be able to cover. but I will try to do this. Okay. Identify those patients, and it is very important. So some of the tools are available and that can be used. So I think all of you know about the proactive identification guidelines by the GSF. It has 3 steps, like one is a surprise question, second is general indicators, and third is disease specific indicators. So those which has been shown like in studies, especially in renal patients. So those who have significant morbidities have a significant impact on the survival. So we see by the modified Charlson score, if it is more than 8, there is mean like it is adversely affected with the quality of life, and they have very reduced prognostication. And other that is important is decreased activity. So again, if it is KPS is less than 40, or if they are bed bound, it is itself a risk factor. Third important thing is like chronic ataxia or weight loss, that, and also it can be indicated by the serum albumin level. That is, if it is less than 2.5, it is again an indicator of decline. And then there are some specific indicators related to kidney diseases. So that can be indicator for patients for kidney supportive care. This is an important study that has been done, and it on patients with 75 or older, and it was identified that in this prognostication score, if it is more than 9, almost 70% of the patients, they died within 6 months, and a lot of patients with like congestive heart failure, diabetes, or active malignancy, they had like bad prognosis. So this is important tool for the nephrologist and palliative care physician to identify the patients whom kidney supportive care or active involvement of palliative care is indicated. And then there's another study that says like in combining the surprise question with age, serum albumin, presence of dementia or peripheral vascular disease may also be an indicator of mortality score and involving the palliative care. So this is about the patients whom we can identify they are fit for involving palliative care. So what is comprehensive conservative care? So the KDIGO, that is an important society of nephrologists, has given a definition of comprehensive conservative care. So it's a planned, holistic, active, patient-centered care for patients with end-stage kidney diseases. That include the interventions to delay the progression, to involve the shared decision-making, a very active symptom control, active and aggressive symptom management approach, detailed communication with the patients and family members, giving a good psychological support and social and family support, and also involving the cultural and spiritual domains of care. So this is basically involving nephrology and palliative care together. And then according to the patient-centered care should be given. It need not to be only like those patients who are not on dialysis. It can also be for the patients who are on dialysis or who doesn't want dialysis. So that is conservative kidney management. So our main pillars are here: the symptom control, communication, psychological support, and also end-of-life care for these patients. So it involves to identify the eligible patients who can be for renal supportive care, then initial and thorough assessment, and based on that the holistic care for the patients on all the dimensions. Very important thing here is goals of care discussions, what the patient really want, what is their belief and the values. and the preference for the dialysis. Is it helping him? Is he burdened out of, because of the dialysis? And advanced care planning, because there are a lot of side effects that can acutely worsen the patient's condition. So if we are able to document the advanced care planning, that is very essential. And then patient may choose for the dialysis or conservative care. But still, even if patient is on dialysis, we should not deny for palliative care, or like he's not for renal supportive care. Still, the patients, we can negotiate the goals and continue the palliative care. Then a next question comes, whether dialysis is absolute for all the patients. So usually this is from Brennan Sir's lecture, like a patient asks, will I live longer if I start the dialysis? So usually the nephrologist or every physician used to tell, yes, you will live longer if you commence on dialysis. So there was a very interesting study by Murtag et al. And it said like there was no benefit of patients on starting dialysis in the patient who are over 75 and who had comorbidities, especially in the IHD group of people. They didn't had any survival benefit, and even some of them had reduced prognosis. So this is in the overall group of patients who was about 75 years age. So there was a dialysis, the benefit with the dialysis. But when we involved, we saw patients who had IHD or comorbidities, the survival benefit was lost. This is same thing we saw in one other study by Chandra et al. That showed that the patients with conservative care lived better than patients on dialysis in the patient who had severe comorbidities. This is another study by Young et al. And it has showed that on all domains of quality of life scores worsened with on dialysis. But in those patients who were in the supportive care group, some of them we were able to maintain without the dialysis. The quality of life we could maintain, although in some domains it worsened. So what is withdrawal of the dialysis? So it simply means the discontinuation of maintenance dialysis. So now the recommendations are the dialysis should not be viewed as the default therapies. We should look actively for as a whole person and other indicators like whether it can be used or not. So there has been some approach for withholding and withdrawing of the dialysis. So we should assess the patient's decision-making capacity, and if he can take the decision, then there should be a shared decision-making, and we should respect the patient's autonomy. Identify if there is any advanced directives or any advanced care planning has been done. Assess for any possible reversible factors. If it is there, correct them first. We can consider a short trial of dialysis if required, if it can benefit. And by that time, patient or family members will also have a fair idea like whether dialysis should be involved or not. And if patient worsens, many times patients also say that, yeah, we can withdraw from the dialysis or withdraw. So always involve the nephrology team, even if required. Dialysis nurse and the dialysis technicians also, they can also a lot of time they say like this patient is not doing well during the dialysis, so involving them is important. And you involve the full family, and there should not be any conflict. And also post withdrawal involve the palliative care actively, and also nephrology should not leave the patient, and they should also follow up with the nephrology team there. So it should be a balanced effort, like there should be benefit versus burden of therapy should be weighed. And according to the principle of ethics, we should recommend whether the withdrawal should be done or not. So here we see, like, if there is a patient's autonomy, if he wishes that he doesn't want for go for dialysis, and it happens very commonly. We see a lot of patients, especially elderly, they do not want to go for dialysis, but it's because of the family, the spouse or the son want him to go for dialysis, and they do not want to lose the patient, and that's the cause many times, and the futile treatment they continue. We should look for other indications, especially the neurological worsening. So those patients with advanced dementia or a severe stroke who cannot take care of themselves, who are bed bound. It has been found that it is a futile condition and we should not recommend dialysis. I think I'm out of time here. I wanted to tell, like, these are the sum of essential reading for every PG student and every palliative care physicians. So at least you should read KDIGO guidelines for supportive care, and also very beautifully that in the Oxford textbook of palliative medicine, and the chapter on ESKD, I think that anyway you will read only. So that has given almost all the things about the supportive care in kidney. There's, if you want to read in details, there is ANZSN guideline, especially the symptom care part they have given very beautifully, and you can read it. And this I wanted to talk about, but the time is less, so you can read this paper, the 10 tips nephrologist wanted to say. And this is very beautifully he had given for palliative care physicians. And thank you so much for patient listening. I think we can quickly take some questions if we have time.
Pankaj, it was so much of, I think it was excellent, Pankaj. In a simple language, you have told so many things about chronic kidney disease. Now, Arun, important questions, because now we are running short of time, but it was required to speak that much from Pankaj. So important questions, Arun, you can ask Pankaj, and we will overshoot time for maybe 5 to 10 minutes. No problem. Okay?
Yes, Pankaj, thank you. Pankaj, one question is about use of buprenorphine in CKD patients that you might see. So can you say about that?
Yeah, actually, I forgot to mention that I wanted to add. Buprenorphine patches are very commonly used and it can be used safely. The principle is same, like we should not directly put the patch. We should try to see the pain, how much opioid requirements are there. So again, it depends on like we should use breakthrough medications or medications that can work immediately. And then if like a patient is getting a good relief with 10 mcg of fentanyl or a tramadol requirement is very less, then we can go for buprenorphine patch also. The safer dose, like buprenorphine is very safe in kidney patient also. So up to 10 mcg usually we use.
Yeah, thank you. And what do you do for neuropathic pain control in CKD? I mean, if you give the medication, some medications come as capsules. How do you tackle that?
Yeah, I think capsule can be used. Yeah, okay. I think the question is like we cannot break the 100 mg capsule into 50 mg. Okay. So now gabapentin and pregabalin both are available as 50 mg also, and pregabalin as 25 also. So it can be used. Because we had seen a lot of patients develop drowsiness if we start with 100 mg. So always we should start with 50 mg if patient is on dialysis or create clearance is less than 15. We should start with 50 only, and it should be alternate day when we are starting, and slowly we can increase to 50 mg daily or then 100 mg daily.
Okay, 7:31. I think we should wind up. Thank you again, Pankaj.